All right, well, thank you for that note. Welcome everybody. We are right at 2 o'clock. I want to respect all of your time. So we're going to go ahead and get started. I know that folks are still trying to join us, but I want to honor your time and we're going to go ahead and get started. I want to thank all of you for being here today. I know it's been a really difficult and challenging time for all of us in so many different ways. So we really appreciate you spending this hour with us, and hopefully you'll find it useful and beneficial. Please, just some housekeeping items. Feel free to put your audio on mute so we don't hear feedback noise. And if you have questions, comments, feedback, please continue to send them through the chat box. I will keep monitoring it, and if we have time towards the end of it, we will take some of those. I guess I didn't introduce myself. I'm Sanjita Pradhan. I'm Director of Talent Development at the Greater Des Moines Partnership. And we've really tried to bring useful information, very responsive to the situation we are in, to all of our members. And so hopefully this is going to be useful for you today. Just quickly want to introduce, we have a great lineup of speakers today. Our partners at World Education Services, national partners, will be speaking to us a little bit, giving us an broad overview in this landscape. And then we are going to have our local expert, Pat Steele, who is the Director of Central Iowa Works at United Way of Central Iowa. So without further ado, I would like to go ahead and pass it over to our West team. Please go ahead and introduce yourself very briefly and take it over. Thank you.
Thanks so much, Sanjita. Thanks so much for having us. We're really pleased to be able to be here this afternoon to share some of the work that Wes and Imprint have been working on over these past couple of months, specifically around healthcare licensing, which I know is of a lot of importance right now in Iowa and all over the country. Just really quickly, I'll talk, just briefly introduce you to Wes and Imprint if you're not familiar with our organization. Wes is a social enterprise nonprofit organization dedicated to helping immigrants, refugees, and international students pursue their educational or professional goals in the US and in Canada. West Global Talent Bridge works with stakeholders, including nonprofits, government agencies, educational institutions around the US, providing technical assistance and other supports. And this is all geared towards helping to remove barriers to employment for immigrants and refugees who are underemployed in the US. And then Imprint is essentially the advocacy arm of WES. We are a loose network of nonprofit organizations from the United States working to advance policies that seek to remove barriers to employment for immigrants and refugees here. You can go on to the next slide. Great. So I talked a little bit about underutilization of skills. What does that mean? We call it brain waste. And the idea is that there are immigrants and refugees in the US who are trained, educated, or have international credentials from their countries of origin. And then they come to the US seeking employment, and they face many barriers when they do that. As a result, they often will take jobs that are lower paying and don't fully utilize their skills. And we sort of broadly talk about this phenomenon as brain waste. You can go to the next slide. So what does this mean? So of the approximately almost 9 million immigrants in the United States, shockingly more than 2 million are underemployed. And this means that we're talking about individuals who have at least a bachelor's degree from outside the United States. Many cases, people have much more than a bachelor's degree or many years of experience, and then they come to the US and they're not able to put that training to use. So just over 2 million people are affected by brain waste in the US. Next slide. And then if we drill down a little bit more and talk about people with health-related degrees, this data is from the Migration Policy Institute. and actually was just released in April. So they did a data analysis and found that overall 263 immigrants were underemployed or unemployed who had health-related degrees. Of that 263,000, approximately 165,000 were trained outside the US, and the remaining roughly 98,000 were trained here. But you'll see, regardless of where training is, immigrants and refugees are suffering from underemployment, and this is particularly problematic in health-related fields as we see that shortages are becoming increasingly more acute. The one thing I'll say about this slide is, of this number, the vast majority of immigrants and refugees affected by brain waste had degrees in nursing. I think something like 114,000 or 118,000, somewhere in one of those numbers, had nursing degrees, but were underemployed in the United States, which is really shocking given the nursing shortages that we expect in the US. Next slide. So then when we talk about Iowa, this is overall for Iowa, it's not specific to health. But overall, 1 in 3 of Iowa's workers are college-educated immigrants. 34% have immigrant workers in Iowa, so people employed in Iowa have a college degree or higher. And then when we talk about brain waste in the state, nearly 23% of immigrants with at least a bachelor's degree are underemployed or unemployed in the state. So 23%. And so what's driving brain waste? What causes this? There are a few different barriers, and obviously this changes depending on a person's individual circumstances, but some of the primary drivers that we have seen based on our work with partners, one is a lack of recognition of their international training or credentials, right? So when people come to the United States, let's say a doctor, for example, they may have years of experience in their country of origin, but they come to the US and they have to completely redo their training in order to get licensed in the US. That situation plays out in many occupations across the board, not just in healthcare, but particularly problematic in the health sector. In addition, people don't have education or US work experience. That can often be a barrier. There's some employer bias that sometimes comes into play there. The third is lack of social capital. What that means essentially is people don't have local professional networks, right? We all rely so much on our networks in order to learn about potential employers, maybe get some access to a potential employer through word of mouth. This is something that is very difficult for immigrants, as is, just basic soft skills. Going through the interview process can sometimes be new for people and very challenging, and people need supports to get through that process. And then finally, of course, a barrier is often individuals, they're English language learners, and they may not be proficient in English, or they may be proficient in English, but they may not have the technical language skills in their field. So, there's very much a need for English language learning programs that are tailored to people's specific professions. So it's not necessarily people are, have to learn English from scratch. They may very well know, but are struggling with certain pieces of English as it relates to their professions. So those are some of the top factors driving brain waste. Again, not all, but they are some of the big ones. And then we can go to the next slide. And I think this is where I actually am going to introduce my colleague, Mike Zimmer, who has been working with us on licensing and temporary licensing for internationally trained immigrants and refugees. So Mike, I'm going to hand it over to you.
Good afternoon, and thank you, Sanjita, for having us participate in this. I have to apologize in advance. I have a rather long history of employment in the licensing world, so I tend to geek out a little bit on licensing. I was a former legal counsel to the governor, a former licensing director, and a former cabinet director. So I've done licensing for a lot of years. Next slide. So when the COVID hit, governors across the country started exercising remarkable flexibility under their emergency order to streamline licensing in a whole host of areas. Things like cross-state licensing, reducing continuing education, allowing applicants to practice at a certain point pending examination requirements. There was some pulling retirees back into service. There was some amazing flexibilities I indicated to bring people in to meet the healthcare demands. West started working with a number of states to see if those states were willing to have their governor exercise that same flexibility to bring internationally trained health professionals into the COVID fight. And I think on the slide in front of you, you will see those states that have issued emergency orders in this area. And I'm trying to think how I'll do this. I think I'll do this starting in the West. Nevada, Governor Sisolak issued what that was an emergency directive that allowed internationally trained healthcare workers in a whole host of different license categories to apply for temporary licensure during the COVID epidemic. They have a fairly unique structure in that state has a chief medical officer who is reviewing all of those applications. So far, they have only licensed a few, but they've got a number of them in the pipeline. But again, they're looking at doctors, nurses, respiratory therapists, a whole scheme of different licensed professionals to help Nevada. The next state is Colorado. Again, Colorado took a slightly different tack. Their governor authorized flexibility through emergency rule. And to date, Colorado has issued emergency rules relative only to doctors, so that it's fairly narrow in Colorado. Switching over, I keep going west to east, Michigan, my home state. Governor Whitmer on April 26th, so again, relatively recently, she was the last of the EOs, issued an emergency order that provides for temporary licensing of individuals with international healthcare experience in limited categories. Physicians, physician assistants, RNs, LPNs, and respiratory therapists. There is a requirements in that executive order that the candidates or applicants have a number of years of service and that their service is relatively recent, i.e. within the last 5 years. They hope with those kind of provisions in place to be able to onboard quickly the internationally trained medical professionals in those categories in Michigan to assist in the COVID fight. I'm going to skip a little bit to New Jersey, which is our rock star state in this. Governor Murphy issued an executive order relative only to doctors first that similar to Michigan had a experience requirement and a age of experience requirement. Excuse me. They have to date received over 900 applicants, 950 applicants as of Tuesday, just for doctors that want to utilize international training and experience in New Jersey in the COVID fight. Again, there's a process. They have to check their credentials, they have to review, but so far they've got 22 licenses that have been issued for people who otherwise would not have been able to utilize their expertise, and a number of others in the pipeline. As I said, the original executive order dealt only with doctors. There was subsequent legislation actually in New Jersey that authorized that same kind of treatment in other professions, and they are now looking at those. The remaining two states, Massachusetts and Nevada, did issue emergency orders, but they were frankly much less far-reaching. In most states, a IMG, an internationally trained doctor, is required to have a 3-year residency, to complete a 3-year residency before they're fully licensed. Excuse me. In Massachusetts, the executive order reduced that to 2. In New York, they reduced that to 1. Next slide.
I have a quick question,
Yeah,
Mike,
sure.
Before we move on, and maybe I missed it. The numbers that you have on each of those states, did you explain what that was, or maybe I missed it?
I think that like New Jersey's numbers that I talked about, is that what you mean?
Yeah, so the 3,000 in Nevada, are those underemployed foreign-born individuals, or the total need?
They are, yep.
Okay.
Yes, so the numbers on the map are the number of underemployed immigrants and refugees with international training. So that I think it was 165,000 number. Of that number, this is the breakdown in the states that have issued executive orders.
Got it. Thank you for that explanation.
And part of the reason I think New Jersey's number of applicants is so high, 950, is that they do not have within their licensing emergency order a residency requirement. So they're getting applications from New York and others. Frankly, they're getting international applications from other countries. Some of the other states who have much less applicants have had a residency requirement in it. So that's sort of one of the lessons learned as we move forward. And I think if I can go off script for just a moment, I think one of the things we're transitioning to now is discussing a long-term license reform to permanently remove barriers for internationally trained healthcare professionals. And we're using sort of the lessons learned in the different architectures of these emergency order states to craft what may be long-term reform proposals. Thank you. No, you switched slides on me. Thanks. When we talk to states about whether they are willing to exercise emergency authority to onboard these internationally trained,
Sorry.
That's all right, internationally trained professionals, these are the factors we look at. First, what are the staffing needs across the state? What's your pipeline? What's your potential pipeline of internationally trained healthcare workers in the state? And what is the demand among the provider sector? In those states where there's significant demand and a significant population available, we've been the most successful in driving emergency order flexibility. The governor has to exhibit a willingness to exercise the emergency authority in this way. And typically, if a governor sees a workforce shortage, that governor has been willing to exercise that kind of authority. How that is done is going to, how it's actually written is going to depend on the sort of regulatory structure in that state. There's a lot of different models. We at West stand ready to assist if Iowa, for example, saw that kind of a disconnect and wanted to pursue this. I think one of the challenges in some states right now is they are not seeing the demand supply disconnect at this moment, either because, primarily in some states, because they did bans on elective surgery, which drove down the natural supply demand curve. And then other states like Colorado, for example, which doesn't really have a disconnect right now, are looking at emergency authority and emergency onboarding to get ready if, in fact, there is a second wave in the fall. But again, we at West stand ready to talk to those either in the provider community, the immigrant community, or the governor's offices on providing technical assistance on how this may be accomplished in their state. Next slide. And it's time for Catherine Geber-Medden.
May I interject just for a second, Catherine, before you move on, which I think I didn't do a really great introduction of why we're hosting this topic, because I have such a great lineup of speakers here today. But as all of you know who are attending this, and hopefully more folks will join us in watch this in recording, the state of our workforce in across the board in all industries is very dire. The talent for war is going to be the #1 issue that we are all going to face in future. And particularly in the healthcare industry, it is even more stark. And so with the COVID pandemic, we got to really see how this is going to affect us. And so we wanted to host this conversation today as a starting point with all of you who are in the industry, who are in the business, and hopefully we can form some sort of a coalition community going forward to continue working. So we just wanted to share with you this overall big picture, what other states are doing, what are some best practices, and what are some solutions. Frankly, I think that's kind of what we want to continue talking about in future. So just wanted to bring that quick little perspective. So Catherine, you can go ahead.
And Sanjita, if I could just wrap that up. With that in mind, A number of states are in fact looking at emergency order COVID responses. A number of other states are looking at it more from the traditional, how do we statutorily or regulatorily break down barriers that preclude people from entering absent the governor's emergency authority? So there's really two discussions linked,
Right.
separate.
Right. So there are different solutions to it, which our speakers, Catherine and Pat, is going to touch on. But this is one of the focus areas at the Greater Des Moines Partnership. We know there's a huge pool of untapped talent, not only in the foreign-born population, but other populations who are historically marginalized, LGBTQ, persons with disability, returning citizens, and so forth. And so this very timely conversation. Catherine?
Thanks, Sanjita, and thanks so much for having me. I think Sanjita is the most famous person I know in Iowa because she's such a rock star in this field, and I know everybody knows that who's met Sanjita. So thank you so much for having us on today. I just want to pick up where Mike left off, really talking about some of the fixes around licensing, particularly in this time of crisis under COVID and some of the work we've been doing. But as Mike mentioned, Wes and Imprint, we've been working on this issue for many, many years, and we're really lucky to have such a great policy team under Jackie and a great consultant in Mike to really help us dig into some of these regulatory barriers that prevent internationally trained folks from resuming their careers. And I think that now more than ever, when you see some of the numbers like Mike mentioned in New Jersey, 900 doctors who aren't able to practice medicine in the US, that are applying to take part, put their lives at risk and contribute. There's a huge untapped talent. I apologize, I have a very loud lawnmower in my background, so I'm hoping folks can still hear me. But I did want to pivot really quickly to talk about take away from kind of the policy side to the program side. And so Sanjita, if you look at the next slide, also as you're thinking about in Iowa how to respond to a workforce shortage, along in the backdrop of probably, I'm guessing, like many states, a very high unemployment number at the moment due to COVID. We know that we're going to need to staff up hospitals, but we also know that we're going to be dealing with massive unemployment and lots of training needs of folks who've been dislocated from the workforce. While I think oftentimes as many of us who've worked on particularly immigrant and refugee workforce issues in the past know that refugees and immigrants are often overlooked. Sometimes within kind of traditional workforce programs, as Jackie mentioned very early in her presentation, things like language that become a barrier for folks and not really customizing our workforce services to meet the needs of the internationally trained immigrants and refugees. But I think in this current time, when we're looking at a population that with very little intervention can be deployed in the healthcare space in the more long-term, right, during COVID and post-COVID, as we try to ramp up our healthcare and our public health infrastructure, this is a great population to invest in for these short-term trainings that can get somebody in a very small amount of time from a nurse who's unemployed or underemployed to a nurse that is practicing in a hospital. So I'm just going to go very briefly over a couple of different programs that we've seen have a lot of promise and just things for you to think about in Iowa as you're problem solving on the much larger issue of developing that healthcare workforce. So a couple best practices, one that's actually up here in the New York area where I'm based at LaGuardia Community College, which is a very large immigrant serving college. They have a Welcome Back Center, and within that they've developed what they call the NIBEST program. It's a contextualized ESL program for nurses that helps them specifically prepare to take the NCLEX exam, which is the exam to become a registered nurse in the United States. And so it's a 9-month intensive program that's a mix of language training and skills training that gets somebody to the point where they can pass the NCLEX exam. They have a very high demand for this class. It's New York. It's a lot of internationally trained medical folks that live in the area. So they always have a long waiting list. But within their program, I believe it's something along the lines of about 90% of their participants pass the NCLEX on the first try, which is much higher than individuals that come out of US nursing schools. So while it is what we would call a boutique program that's very aimed at one particular population in a state like Iowa, particularly again post-COVID, if you're looking at nursing shortages and you know that you have folks, you know that programs like this will also recruit folks to move to Iowa for these types of trainings, because there's so few of them in the United States that you know, it's like the field of dreams. When you build it, they will come. And so I think also when folks are looking at attracting talent from the region, and I know from working with Sanjita that, you know, Iowa and Nebraska have a little bit of a rivalry. So this is a kind of an example of these types of programs will also attract immigrants to your community to take part and really be able to contribute. So we left a link in there, and we'll send this out, you know, after, so you can really take time to learn about the programs. But I'll go into the next one and just two more that I'll talk about, and then I'm going to hand it over to Pat. Another program is in Minnesota, and it serves doctors. One of the biggest barriers for internationally trained doctors is the residency requirement. So any of you working in hospitals or with healthcare professionals know that, you know, passing the USMLE exams is quite difficult, but many international doctors can do that. But getting a residency is its own particular challenge. And so in Minnesota, they've developed a program to really help people get that clinical experience and be able to facilitate, you know, the move into residency. And so that's a pretty unique program as well. And it's run at the state level. So again, a neighboring state of yours as well. So something to look at. And the next slide, Sanjita, which is my last. Oh. And another is, you know, we have a wonderful partner and founding member of the Imprint Coalition, the Welcome Back Initiative, that has been working, and you can see the blue states across this map, has been working in different communities for the past, I believe, 15 or even more years, standing up programs that are local to help advise internationally trained medical professionals. All of these programs look a little differently. Some of them are housed in departments of health. Some of them are housed in community colleges. You know, some are housed in refugee resettlement agencies, but they all serve internationally trained healthcare professionals. And the LaGuardia program that I mentioned earlier is housed in a Welcome Back Center that also provides other services. And so the work that we've done programmatically over the past few years with Wes, we found a lot of communities really wanting to start Welcome Back initiatives and really help build that bridge between folks who are out of work in the healthcare sector and those employers that are looking for talent. And that middle ground is really, how do you advise folks on the career pathways, on the exams they have to take, on the other steps they may have to take to fulfill those requirements, which is often very complicated and varies from state to state. So that's another model, a national model to look at. And finally, I think we just have one more slide. If you love to look around at information and data, we actually have a really great map on our Imprint website that maps programs across the country that serve internationally trained professionals. They're not all focused on medicine. In fact, most are more general and broad, that are serving folks from all professions. But if you want to take a look at that map and see what's in your neck of the woods and around you, and look at other programmatic best practices, you can definitely check out that website. And I know Sanjita is going to send my contact information on my colleagues. So as you're thinking about next steps here in this space, you know, we'd love to continue the conversation, whether it's about licensing, whether it's about programs, whether it's about policy. This is the team you're looking at here on the West Side, and we're always happy to be a resource. So thank you again for the opportunity, and happy to stay on and answer questions later. Thank you, guys.
Thank you very much, Jackie, Mike, and Catherine. Please stick around. And folks, as you are listening in, we have some questions that have come in, concerns that have come in the chat that we can get to. But I'll just take a minute to say we are in this map, Greater Des Moines Partnership. This is exactly why we started this initiative, Global DSM, 3 years ago. And I was brought on to provide services to foreign-born individuals who come to our communities with foreign degrees and diplomas and are under or unemployed. So lots of people with PhD degrees, master's degrees, doctors, engineers, name it, I've met them. I meet with them on a regular basis and provide guidance, counseling, classes on career readiness. While there are career readiness classes available in the community, there aren't any that comes with a high-skilled immigrant lens. So if you're a doctor, if you're a PhD, if you have a PhD or a master's in a specific field or an engineer, there aren't any places where they can go to get the right services. As you may already know, there are only certain places where people go to first in the state to find help when they're looking for employment. And none of those places were equipped to serve high-skilled immigrants. It requires a specific support system. It requires just a slightly different way of supporting and helping them. So that's kind of what we do at the Greater Des Moines Partnership. And again, we need everybody on board. This is an issue that cannot be solved by one agency or institution, and we need all of you to be partners with us. That's how we ended up partnering with Pat Steele. I just will be remiss to talk about a few examples of folks that I have personally met. I will say that in the last 3 years, I have met a large number of people who have healthcare background in their home countries. And so they are all doing other kinds of jobs. I met a person who had a medical degree, and she came from Brazil, and she just had missed her time to give USMLE exam. There's a lot of pep talking required, as you know, somebody who's been a doctor and practiced as a doctor for many years in a country. It's not easy for them to finally know at age, let's say 40, 43, whatever age they are, that they will never become a doctor again. But they have a skill that they can contribute to, and it's a skill we're all looking for. So eventually she did a nursing course, and I haven't caught up with her lately. That's one example. Similar other example of a doctor who was educated outside the office, similar situation, missed the mark to give the USMLE exam. With the support of our local partners, Mercy College, through our relationship, they hired her as an adjunct faculty. She cannot practice, but she has all the knowledge. So I think that's a great way to partner. Sometimes people have unconscious biases. There are policies and reasons why we cannot hire them, but also sometimes, we need to go beyond, our hiring practices and look at uncommon sources where we've not gone before. If it was not for working with us, Mercy would not have found her, and she would not have found Mercy. After working there for a few, I guess a whole year as a part-time person, she was excited to share with me that Mercy brought her on as a full-time faculty. So these are ways, one at a time, one step at a time, one person at a time, we can all make a difference. And so just wanted to give you a little bit introduction of what we do at the partnership and why we are in this area. So Pat, I think I'm stealing from your time.
Oh, that's okay, Sanjita. Good comments that you made. So thanks a lot to Mike and Jackie and Catherine, to appreciate you taking time to help us maybe sort through some issues here in Iowa and address the healthcare workforce shortage that we have. As you can see up on the screen there, prior to the pandemic, healthcare was the fastest growing sector. You can see particularly long-term care, home health aides, so really tremendous needs there that we have not been able to meet. Over 8,000 job vacancies, that was prior to the pandemic, but although the pandemic has created some job loss, most economists, labor market officials figure that the healthcare sector will bounce back pretty quickly once we get to the other side of the pandemic. And it'll continue to be a challenge for us here in Iowa, meeting all the healthcare needs that we have. Next slide, Sanjita. Our shortages at every level. The University of Iowa Carver College did their survey and found that the state is about over 360 physicians short in a variety of specialties. the Iowa Board of Nursing. We have just about 48,000 nurses here in Iowa, and not quite half, but getting pretty close, are 50 and older, and 22%, almost a quarter of them are eligible to retire now. Whether they do or not, don't know, but nursing can be a pretty physically demanding position. So when you have that percentage who are 50 or older, it's got to raise some concern for us as a state. And then the licensed practical nurses, the LPNs, the 1 year, typically a 1 year program, we're looking at well over a third of them are 50 or older, and nearly 20% are eligible to retire right now. Looking at the next slide, which we take a look at the direct care workforce. There we go. Di Finley and her group, the Iowa Caregivers Association, have done a study, and you can see the number of direct care workers we have, just about 43,000. And you take a look at that age range, 7% of them are over 61 years of age. And 10% of that direct care workforce plan to retire in the next 5 years. So that's a daunting statistic in front of us. And then not only is our workforce aging, but our nursing instructors as well. We have a little over 1,000 faculty members in state who train our healthcare workers, nurses, et cetera. And 37% of them are over 50 years of age, and about 60 of them intend to retire within 2 years. And even prior to that retirement, we already have 43 nursing faculty vacancies in Iowa. The challenge here is we don't pay our nursing faculty very well. So it can be difficult to attract them to be instructors because our pay is not as good as it should be. And it's not as good in a lot of other areas as well. Next slide, Sanjita. We also have population challenges. Iowa has been on pretty steady but slow population growth. We have reversed the trends back from 20, 30 years ago when we were losing population. We are no longer losing population, but we are not growing rapidly. And that's really been our fate for the last 100 years or so. We have been a very slow growing state, and there's nothing that indicates we're going to have lots of people moving to Iowa. So which really calls on us is that we have got to be able to use all the populations we have here now to meet our needs. So you can see over the next decade, we expect to grow by about 5%, and that's about the middle of the pack in states. Some states obviously grow much faster, others a little bit slower, but that's where we're projected to grow. And we're going to get older. You can see about nearly a quarter of our population by the year 2020 or 2030 is going to be 65 years or older, and that's a pretty significant increase from the year 2000. That really reflects the large generation of baby boomers as they age, and that's going to have a major impact not only in healthcare but in other parts of our society as well. Next slide. And diversity. This, as a state, we struggle with this in many areas, and our healthcare workforce is no exception. 94% of the nurses in Iowa are women, and 96% of them are white or Caucasian. And as you can take a look at LPNs, pretty similar statistics, 95% women and 92% are Caucasian. So we have got to find ways to have people of color be able to advance up the healthcare pipeline, so to speak. The direct care workforce is a little more diverse, with about 91% being women and 78% Caucasian. But these also demonstrate another challenge we have, and that's what we sometimes refer to as occupational segregation, where people of color and foreign-born are often clustered in lower-paying healthcare jobs. That's not unique to Iowa. We're not the only state with this challenge, but it is one for us. And again, as I mentioned earlier, we have to find ways for people of color and foreign-born to be able to climb that ladder where they can get to better paying jobs. And next slide, Sanjita. So, with our healthcare workforce, there is no one magic button. If there was, we would have found it by now. It's a combination of factors. And I think we have seen with the pandemic the last 3 or 4 months, and then the protests of the last week or so in America, we clearly are a country in a crisis. And as was once said, never let a good crisis go to waste. So this is an opportunity to kind of revamp, relook at our healthcare system, and what can we do to make sure that it's prepared for the next pandemic, or if not pandemic, just prepared to deal with the kinds of demographic changes we have, the aging population, lack of growth in the state of Iowa population. So how do we tap in so we make sure that all of us have the healthcare providers and system that we need as a state? So first up, we need to diversify the healthcare workforce. At Central Iowa Works, we have had a Department of Labor grant the last 4 years, and that grant was intended to increase the number of healthcare workers in Central Iowa. One of our goals was that project was to increase the opportunities for people of color and foreign-born to get into healthcare jobs. Our goal was that 30% of the people we enroll in our healthcare project would be people of color or foreign-born. We have exceeded that. That's about 70% of the people we've enrolled these last 4 years have been people of color and foreign-born. So we're pleased with that. We also took a look to see how people of color are doing on our programs in terms of program completion, job placement, and job retention. And overall, they fare about the same as Caucasians. So African Americans, Latinx, Asian Americans are all finishing programs, getting jobs, staying in jobs at about the same rate as the persons who are white in our program. But what our study did show was that there was not much advancement of people of color beyond the direct care level, the CNA, home health aides, community support living supervisors. So that's the problem that we have. We just recently did a focus group with that, trying to identify what were the problems, what do we need to do to make it easier for people of color to advance in healthcare. And that may be a topic for another webinar that we do. Second is educating and training the healthcare workforce. Showed you statistics about the faculty, the aging faculty, the number of vacancies we have, the difficulty in attracting faculty. So I think in healthcare, I think there needs to be a shift to a little more of a work-based learning apprenticeship approach where people can go to work and then take classes, much like we see in the trades and construction and other industries where they go to work, they work in the field, they also take classes at the same time, so they don't have to stop working completely while they go to school, but they can work and go to school simultaneously. Here in Central Iowa, Broadlawns Medical Center has started an apprenticeship program in CNA and Unity Point in CMA, Certified Medical Assistant. So I think those are, I hope, a couple harbingers of things to come that we can do in terms of how we train our healthcare workforce. Third, improving working conditions for healthcare workers. I believe it had to sadden all of us to see us sending our healthcare workers in to treat COVID patients with inadequate personal protection equipment. That was inexcusable. As a state and a country, we should never ask people to take on jobs if we can't properly equip them. And so that's one working condition we clearly need to address. But we have other issues as well, and pay and benefits are those. Nick raised a question earlier about pay for nurses in Iowa. Do we rank worst? Nope, but we're in the neighborhood. The only states that pay less than Iowa nurses are Alabama, Mississippi, and South Dakota. So that's where we are. The average nurse in America makes about $34 an hour. Here in Iowa, it's about 27. You take a look at the states around the Midwest, which would be our competitors or bordering states. Minnesota's average hourly wage for their nurses is $31.87 an hour. Illinois, $31.51. Missouri, a little, about 30.5. Wisconsin pays pretty well, $33.27. As I mentioned, South Dakota does pay less than Iowa. Nebraska, is just around $30 an hour, just shy of that. North Dakota is up over 30, and Kansas is just around 28.82 an hour. So that's what we need to address, is why are our nurses now, right? Cost of living differences between New York, California, New Jersey, Iowa, to be sure, but certainly not that much. And when you take a look at our bordering states in the Midwest, only South Dakota pays less than what we do. And with our direct care workers, the median wage, according to the Iowa Caregivers Survey, is $13.80 an hour. One cannot support even himself or herself in that wage, let alone a family. So we have got to address that. We have many direct care workers who would love to stay as a direct care worker, but they just simply can't afford to do it. So they have a couple of options. Either one, go to another field or sector where they can make more money, or try to advance with their education to get into the higher paid jobs such as nurses and techs, et cetera. But we really need direct care workers for both seniors and individuals with disabilities. And so we need to come up with ways to provide better pay so that they can stay in that profession that many of them love to do. They just can't take a vow of poverty in order to stay in the profession. So we've got to take a look at this. As I said, this is an opportunity. I think we all sense in this country that the ground is moving underneath us, and we need some real transformation of workforce practices, not only in healthcare, but across almost all sectors. And this is our opportunity to do so, whether it's policy and advocacy we need to do, recruiting strategies, changing how we train people, et cetera. So we've got a challenge ahead of us in healthcare. I think we know what the solutions are, and it's just a matter of whether we can muscle up the strength and determination to make life better for our healthcare professionals, which in turn makes life better for all of us, because all of us came in this world with the assistance of a healthcare worker, and we're going to need healthcare assistance throughout our lifetime. So it behooves all of us to improve the working conditions and pay and training of our healthcare workforce. And then finally, as we've heard from Jackie and Catherine and Mike, we need to better utilization of foreign trained healthcare professionals. It really is a brain drain for the countries they left, and a waste of their talents here for them not to be working in healthcare when we have such shortages and acute needs. So we've got to work ahead of us, but it's doable, but it's time to get started now. So I'll pause there, Sanjita, and see where we want to go if there's any questions that people have.
All right, awesome. Thank you so very much, Pat. Incredible. I feel very, I don't know how you all feel when you hear these statistics, but I say it's mind-boggling. And we need to collaborate and do something together. And we are ready at the partnership to collaborate with you, all of you. If there are any employers here today, we've been talking about this apprenticeship model for so long. That is really a great way for us to get our foreign-born population get started. Again, I know all of you have probably talked about apprenticeship models too, but let's rally around, let's see what the roadblocks are, and let's try and have some leaders here in our community to start it, and others will follow. Pat, I think you're so right. There is no one silver bullet. There's multi-prong approach. I think we all continue to talk to our educational partners about how to make education accessible. I think there is a comment here in the chat box about making our affordable trainings or even free. I think bigger states I have seen in New York, Catherine, you may know a little bit more about that, has some free certification and training programs. I'm not quite versed in how that becomes free and where the money comes from, but together we can explore things like that. And again, in the recruiting side of world, at the partnership, I also lead our diversity and inclusion initiatives. And what better time right now to talk about inequities, to talk about biases, to talk about hiring biases, and it is real, and it happens all the time. I also wanted to share two other examples of candidates that I'm working with. One of them is from Uganda, and he has a master's degree in public health, He also completed a certification program at Drake University in leadership. He's been working in one of our local hospitals in the laundry department for many years. How frustrating can that be and is for him? I can't imagine. There's something in the system that every single time he applies for any position just doesn't get it, just doesn't get through. How can we solve that? We are available here to work with our employers on some of these training programs to talk about diversity, inclusion, how that makes a difference, hiring biases, how do you do inclusive hiring, how do you do inclusive advertising, how do you do inclusive recruitment. So we know we have that information, we're happy to share with you. And then lastly, I think policy. Again, all of you probably are already involved in advocacy, but I think it's time for us to come together and do something collaboratively. I want to give an opportunity for folks who have sent in some chat messages, if you wanted to unmute yourself and speak up, or just share something. What are you seeing? What are some solutions that you have? What are you experiencing? What are some solutions that you have? As you can heard here in our call today, WES has worked with so many states, so many partners across all states, and they are a wealth of resource. So they are always available. They have national advocacy team that we can piggyback on and rely on to work together with. And Pat, as you have all heard from him, is very knowledgeable and has been doing this work for a very long time. So I want to open up. Does anybody want to unmute themselves and chime in? Hearing none, seeing none, I guess. I want to give an opportunity to Mike, Catherine, or Jackie if there were any additional thoughts that came to your mind, if anybody wanted to share something. Otherwise,
sorry, I was just going to say, again, thank you for having us, Sanjita, and just again, you can see our websites are there, and I know Sanjita can send our contact information. So as questions come up more on the national landscape, we're always happy to be a resource, and we're been very close partners of the partnership and of Sanjita. So very connected to your community and happy to continue to have this conversation. So thank you so much for having us.
This is Mike. I'm just actually looking at one of the comments in the chat box on training being suspended with CNAs because of COVID. And I don't know who put that in there, but there are a number of governors that have suspended. Michigan and Minnesota come to mind right away, that have suspended training requirements for CNA registration during the pendency of the COVID epidemic. I know from prior conversations that Iowa has a more onerous than usual CNA licensing process, but it may be something you guys want to explore. Another thing, and I think nationally people are looking at CNAs, and part of the challenge, frankly, with CNAs is the low pay rate. So how do we increase, and it may be federal CMS reimbursement or whatever, so that we can make CNA a more attractive pathway financially for those with international training?
I had heard you say this in one other call, that Iowa is probably the only state or very few states who require an exam to become a CNA. Yeah. Can you shed some light on that? And
a lot of the states that you have CNAs treated as a full license, correct? A lot of states treat CNAs as registrants, which means they are primarily trained by the regulated healthcare providers and get on the registry that way. And there is no specific test. There are training requirements, but typically the healthcare provider onboards their own CNAs and the state approves the training protocols, but it's not full licensing.
Amy, is there something you wanted to share?
Yeah, I just wanted to say that it is, while they have suspended that you have to be registered in order to start working, a lot of times our clients while they could technically get hired, they're not going to get hired. So a lot of times it's the class that kind of gets their foot in the door, because
Yeah.
with backgrounds or with English language learners, that kind of thing, like, yeah, they could technically get hired, but the class and the support is what actually gets them in the door.
I think the success in other states is that, especially in the nursing home community, is that the larger nursing home providers actually offer the classes and do the recruitment at that stage.
Yeah. And some hospitals here have had to start doing that. And so we have seen some success with those kind of programs. And I think it is out of necessity for those people that has made it happen.
Yeah, the key in a lot of this is the necessity may have caused it to happen, but let's institutionalize the necessity and make sure it continues, right?
Yeah.
All right. Well, thank you, everyone. I think we may be able to give a few minutes of your precious time back to you today. Again, thank you for taking time to be on this call today. As we all saw, there's clearly a problem, there's clearly a need, and there's clearly a need for all of us to come together and work together. Individually, I know many of you do this work and champion this in different ways. Pat spends a lot of time in this work, and I spend some. I can't say I spend a whole lot because there's too many responsibilities. But Pat, I think I'll let you say some last words on maybe how can we come together, what's our role, what should we be doing in future, and then I will maybe give a few minutes of your precious time back.
I'll be brief, Sanjita, because I know you're heading on your mini vacation, and we're the only thing between you and your vacation. So thanks for listening in. I think there was some policy and advocacy work we need to do. And we typically do that over the summer months and get a package of recommendations ready for the legislature to consider. So we'll start working on that this summer and put some ideas together, probably touching all the subjects we discussed today. So thanks again to the partnership, Sanjita, for hosting this. Appreciate it.
All right. Thank you. And thank you, our West team, Catherine, Mike, Jackie, Amy, Pat. Thank you very much, everyone. Have a good day. Bye-bye.